So, ladies and gentlemen, it's a pleasure to be here to present this work. So, it's far from the environment. It is environment, but it is also health in humans. So, I will talk first is context and first COVID-19 and my personal context. So, in my life of researcher, I work on two things. First, fishing bugs, and I always fish bugs, bacteria, viruses. So, the most important part. At the beginning, I was searching bacteria in cooling tower. The idea was that Legionella, maybe you know Legionella pneumophila, is a bacterium that lives inside the amoeba. It is an agent of pneumonia, severe pneumonia. So at the beginning, I tried to search other bacteria like Legionella, but using amoeba as a support of culture. So I isolate a lot of bacteria like that and the Bosea of Herbe and a lot of other species, other new Legionella we describe. By searching this bacteria in environment with amoeba, we began to discover the giant viruses. So it was a new word. So the first one was MEPHI virus. I did not isolate MEPHI virus. It's a guy in England who isolates that, but he imagined that it was a bacterium. So he sent me this bacterium, and he said me, I can identify this bug, so maybe you should identify this. He sent me that. I think, oh, it's easy. At this period for microbiologists, we had the 16S RNA, so I said, okay, we do a 16S RNA sequencing and we'll know what it is, but there was no 16S RNA in this bug. And at the end, we go to electron microscopy, and electron microscopy, we see that it was a very, very big virus. And it is the beginning of a story we did with the team of Jean-Michel Clavry, also in the university. And we described this giant virus, so the first giant virus, and after other giant virus, and after virophage. Virophage, it is like a phage, but it is a small virus that infects the big virus. And after we discovered the MEPHI system, it's the equivalent of a CRISPR system, but for viruses. And the other part of my work, because people always say to me, no, but you are a medical doctor and you can work only on the environment. So I had to work for patients. So my choice was also to work with dangerous bugs. And I was the head of the biosafety level 3 laboratory in Marseille Hospital, and now in EHU, that is the largest biosafety level 3 laboratory in Europe. So it's a very, very, very big lab. And with that, I work on typhus, on plague, on anthrax, on tularemia. I began to work on anthrax at the moment of you remember, after the 11th of September, when people after receive the powder, it is a period I began to work on that. After the context of the COVID-19 in our institute, it is here, ça marche? Oui, here. So it's a EHU Méditerranée Infection. So it's a large building with 3 parts. A part for patients that are, it's a building for infectious disease, for treating people, doing research and diagnosis. So there are 3 parts. A part for patients, 75 rooms for patients that are infected. There is a part for diagnosis. So the diagnosis is in this building, it is a first level. After you have a level for research. Here it's a biosafety level 3, and after it is offices. And the last part is that's all for the building. So, you remember in February 2020, it was later for us. I will explain you why it was later in Marseille. But we began with the epidemic of COVID-19. And you remember, I think you remember, it was a chaos at the beginning. And there was 2 strategies. So we had the strategy of the French Ministry of Health and its scientific council, and say the recommendation was to stay at home. They say, okay, you stay at home, don't go to the hospital or to the general practitioner, you need to stay at home to reduce the contamination.
They said you don't need to be tested. The tests are not useful, so you stay at home and you don't test. You don't need to wear a mask. Mask is not useful except for the professional. If you are severely ill, if you are dying, you call you call emergency, and the SAMU, the medical help, if it's urgent, that come to take you with an ambulance and come back to the emergency ward. You call them. If you want to be treated for the severe case, you need to use remdesivir. So it was a new drug from a laboratory. It was 1,000 euro the treatment. So it was very expensive, only intravenous. So and the last thing is for elderly in nursing home. They remain in nursing home, and we had to, the people in nursing home have to give them a palliative treatment. It is clonazepam. It's like euthanasia. Okay, and at the beginning we did exactly not that. We did the choice to test all the patients, all the people who came to the institute. They say, I want to be tested. We tested the patient. All the patients that were positive were examined by a doctor. Of course, we had a lot of doctors because all the practitioners, they closed their activity, so they had time. So they come to the institute to help us to see the patients. The patient with hypoxemia or risk factor had all a CT scan to see if there is effectively to have an idea of the injury of the lung, and for some of them we could hospitalize them and give the treatment. There was no treatment. First we give oxygen. It was the main thing. When they were not hospitalized, we recommend them to come back 3 days after to see if they are okay or if they are worsening. And there was a treatment, proposed treatment, so systematic wear a mask when you are positive, anticoagulant for certain people, and the hydroxychloroquine azithromycin. And this part, the history will take only that in the future. We give that this treatment, and with the devil is Didier Raoult. And at the end, they reduce all we did to only this. And it's not a good idea because all this strategy after, except that, became the strategy of the Ministry of Health, but 6-9 months later. So why searching bugs, in fact, in the sewage? So we test all the patients coming at the institute, but after it became crazy. At the moment, we see 8,000 patients every day. So it was crazy, and we had not the level to welcome so large number of people, because we have wild queues of several hundred meters. It was incredible to see that close to the institute. You have a queue, they turn around. It was incredible. Of course, there was altercation in the queue because, there was 2 queues, and no, I come before you. Some people come very early in the morning. Because at this period I was working the day and the night. So sometimes I come at 5 hours of the morning, 5 a.m., and there were people waiting to do the test. It was incredible. And it was very long to have a registration, and the building entrance was blocked. So it was the limit of our strategy to decide to test everybody. And so we were saved by the Battalion of Marseille firefighter. Excuse me. This is le BMPM, donc Bataillon des Marins-Pompiers de Marseille. It is firefighters, you see their ambulance here. And they spontaneously come to us and say, we can help you because we have time. The firefighters, they work is are devoted to fire, but also to accident on the road and a lot of things. But at this period, everybody was at home, so they are nowhere. So they had time to help, and this is the reason they came to elders to wait and to do the pre-registration of patients. You know, here they had a tent, and in this tent, the people came, they organized a queue, and after that, people go in our building. And at that period, we are regular meeting with the firefighters, and I began to discuss with them. And at that time, they say me, you know, we have a unit, they call that NRBC. NR, c'est nuclear, NR, bacteriologic, chimic. And so they are able, in case of industrial accident, they have an expertise. And they try to do this expertise in the sewage of Marseille. They were searching for the COVID. And we discussed together, and they said me, you know, Professor, it's very interesting. We detect the virus in the sewage. I was not very enthusiastic. I say to the guy, it was Alexandre Lacoste, I say, Alexandre, okay, send me your data and I will see. And it was incredible for me, because we could see that the level of virus in the sewage was exactly the same that the curve we have on the patients. So it was the beginning, we began to collaborate about this subject. So we did several different things. So between July and December of the 2020, we tested the two networks of Marseille. I will explain you what are these networks. And we compared that with the data for patients, because at this period, we are the unique laboratory in all Marseille to do the test. So we are sure that all the patients were tested in our laboratory. After that, we discussed with them and I said we could also try to do the sequencing in the sewage to see if there is a circulation of variants. So, okay, we did that. We did that in a period that the main variant was the Yucca variant. After that, we did that, but by district. Okay, the idea was to see in the different districts of Marseille where the population can be different. You have a rich district, poor district, and people coming from different areas, and they are separated in districts. So the goal was to see if there was difference in the epidemiology of variants. And at the end, we did a pilot study in the Marseille airport to see if it was possible by sequencing, not only detection. On detection, it was done by another team, but we were the first to search by genome sequencing, to search for the genome of COVID-19, for SARS-CoV-2 in the sewage. And after we continue now to do that for other respiratory viruses. So first, it was logical to test the sewage after that, because, because before I discussed with the BMPM, we knew that it was possible to detect the virus in the stools, and even we could isolate one strain in the stool of a patient, an immunocompromised patient, so the viral load was probably very high, but it was possible to isolate the virus, so it was living in the stool. So if it is living in the stool, it's evident that it is possible to detect it in the sewage. The second thing, our second question was, is it dead or alive? So dead or alive. So I discussed with my colleague of BMPM. I say, I need a very fresh sample. So we go to take the sample, and it came directly to the laboratory. And we try to isolate the virus and to observe it with electron microscopy and correlative microscopy. And it was evident that the virus was, here you see, it's a particle of SARS-CoV-2, but it has lost its crown. It is without spike protein, so it's probably non-infectant. And the second thing, we try to isolate the SARS-CoV-2, but the problem in the sewage, there are a lot of adenovirus and enteroviruses, and they grow very well. So it was impossible to grow the SARS-CoV-2. I think it is dead, but we are not exactly sure. Besides our work, there was a preliminary report in Paris. So it was the first publication about this. It was in Paris sewers. And they show, it was in MEPHI, I think, well, MEPHI. In MEPHI, they show that the viral level in sewage was identical to the fatal cases and to the cases in Paris. So it was very well correlated. So it is the first evidence of correlation. So it's an early treatment, but we'll see that they did a mistake after. So we did the same thing in Marseille. So in Marseille, the sewage is organized in two sewers. You have in green, they call that REU. So it is sewage, but you have also the rainwater in this sewage. In the red, it's called separative or separated sewer. It is only, there is no rain, no water in this sewage. So the idea was to see if we think that to test this was dangerous because if you have a lot of rain, you have the risk to have a dilution. During this period, maybe you remember this period, there was no rain during this period, so it was not very important after. And so the guy of the BMPM did that on the biofire, so it was very expensive because this system is not quantitative. So to do that quantitative, they do dilution and they test all the dilution. But each test is 200 euros a test. So it was very expensive, but they have a lot of money. So we compared the two during this period. We compared, so you have two things, the unitary and the separative, and you see that grossly it's quite similar. The curves are approximately the same, and where there was raining, it was not changing the concentration of the virus. But it rained very few. You know, here you have rain, and you have an increase after the rain. So it's not associated to something. And well, this was the first paper we could publish on this work. So it was very nice. So you have following the amount of patients. So we had that in our hospital. It was a positive case in blue. And you have the level of the virus in the sewage. So it was very interesting. So what the most interesting for me was that, you know, that the lockdown was done here. So the lockdown was done, the virus was, it was finished. The maximum of the virus, it was here. So they started the lockdown, the virus began to slow down. You will see that after that, what you do on the epidemic, you have an oscillation of the virus, and that does not change. And in fact, nothing changes nothing. You wear a mask, you close the restaurant, after you open the restaurant, and this was changing every month. It was crazy. But at the end, there was nothing really correlated. The unique thing curious was that, you know, here, it's the start of the academic year, okay, the people of Marseille come back to Marseille and the tourists go back. And this is the only thing different. And we'll see that after, but we believe that this is the reason of the discrepancy at this period here. There is a discrepancy only at this period, and it was the summer period, after the summer period. So what happened in Paris? In Paris, they say, okay, they did the lockdown here, and after the lockdown, there was a reduction in the virus 20 years after. So the conclusion was, when you do a lockdown, 20 days after, there is a the virus disappears. The problem is that it does not work in Marseille, because in Marseille, the lockdown was here, so the virus was low here, and we had a lockdown here, and after, in fact, in Marseille, the lockdown in France was decided by Paris, by the capital, but Marseille is not Paris, so it has no effect, you see, and it is easy to understand, but for people who are from France, it's easy to understand, you know, Paris, it's here, it's in influence of the world, of all the world, but you have UK and all the area. In Marseille, it's different. Marseille, you have people from Italy, people from Spain, and people from North Africa. So we have not the same people, and this is not the same epidemiology. So each time in Paris, they say to me, okay, it is very important to do a lockdown. But we say, no, it's not useful. We don't want to be at home. But they decided to continue. They continue until here. But after that, here, there was no lockdown, and the virus decreased also without any lockdown. So here, you have the representation of the last, 2021, so the last 2 years. And you have the SARS-CoV-2 per copy of genome of the genome. And you see that you have all this wave, successive, and this continue. Here it was in April. I don't know what should happen. It's possible that we have a wave during the summer and the second wave during the winter, like the other years. But we will see what will happen. But you see here, the number of cases is lower. Here it was well correlated, and here it's less correlated. The reason of that is because people are not tested. If you don't test people, you don't know that you have so much cases. So the interest to survey the virus in the sewage is that you have something that is independent of the politic of testing, or of hospitalization, of the severity of the disease. It is completely independent. So it is the reason it's very, very interesting. So the conclusion for this fourth part, this sewage analysis was very interesting to monitor the virus circulation. So it is important to analyze the control measure, and neither the lockdown, nor the vaccination, nor the health passes, or everything had any effect on the virus circulation. And this continue after. Even when all people were vaccinated, this did not modify the circulation of the virus. The vaccination did lower the number of fatal cases, that's true, approximately 50% less, but did not modify the circulation of the virus. And you see here you have the different variants, and you see that all these variants have oscillation. And this oscillation is very curious, because at the beginning, the people say, okay, after the first epidemic wave, people talk about the immunity, collective immunity. It was collective immunity. But during this first wave, not all people were infected. It was less than 10%. So what happened with the 90% remaining? In fact, the virus, during an epidemic, it increased, and after it is lowering, and there is no explanation of that. It's probably the most fascinating thing. So I have a colleague working on that, and he has a theory that I think is very good. In fact, he did the genome sequence of all the viruses during the epidemic, and what we can see is that a virus, it's RNA virus. RNA virus accumulate a lot of mutation. Okay, the polymerase has not a good correction, and so it accumulates a lot of mutation, and all these mutations are defective. And after accumulating a lot of mutation, and then the virus decreases. But sometimes there is a good mutation, a favorable mutation. So you can have a new epidemic, and after this is the same story happening all the time. And it is not related probably with immunity, but it is related with the virus. And this is probably the same for all the respiratory viruses, RNA viruses. The second thing, it is interesting, but there are confounding factors. So rain, I said, in Marseille, it was not the case. So it's raining for 5 days, actually, but this never happens, I'm sure.
It's because of ICB. Buenos Aires, in Argentina, it was the same.
Okay.
It was raining all the time.
It's incredible to have this rain. That does not happen usually. Okay, so you have the movement of population. You know, when some of you maybe went to Venezia, you know Venezia, and you see when you go in Venezia, you have the center of the city, and you can imagine that you have thousands of people go here in the cafe, the restaurant. You can imagine that you have an increase of the concentration of the virus. But after, they go back on the boat, and the number of cases is only the number of the population of Venezia. So you can have very high level of virus in the sewage, but in fact, there is a very few cases. The last thing is it's possible to have a viral expression different according variants. Not all the variants have the same level of multiplication. And we see that during the Delta variant. Here you have the CT value, so the number of, schematically it's the number of copy. And you see the number of copies, so the CT decrease, the number increase. And you see that during the epidemics as it is Wuhan, and this is the Delta variant, Indian if you want. And you see that the Indian variant, the viral load was higher. So for the same number of patients, you will have more virus in the sewage. And the last thing, this one, we could not explain that. You see, you have an oscillation of the case. Here it's okay, it's increased. But here, there was a very, very, very high peak. So this high peak was not associated with a high number of cases. So this one, we have an explanation, but we are not sure of that. We think that it is a returning of people from Comoro. You know, there is a large community of Comorians in Marseille, and this corresponds to the return of Comorians in Marseille. And the South African variant, that was also in Comoro, at very high level also of copy. So we think that is sad, but we didn't demonstrate. It is an hypothesis. We'll see that we'll add also something interesting with Comoro. So there are solutions to avoid this problem, but none is perfect. It is possible to normalize the genome copies by freeze drying. You know, when you see, if you say that the water is diluting, you can use that, freeze dry, and calculate the number of copies on the freeze dried material. You can normalize also with viruses that are supposed to be present in each time at the same level for everybody. So it's a paper mold virus or the crasphage. This is like a control that gives you the level of stool contamination. And the last, you can normalize also the value you obtain according to the CT value in the patient. But it's very difficult to do that. So after that, we decide to try. After that, we know that it's possible to follow the epidemic with the virus. We try to see if it was possible to follow the genomes of the virus in the sewage. So first, before doing this, we had to do a small work to prepare the sample. Because when I start this work, I do the bibliography. The bibliography is very, very complex. And most of the protocols that are proposed are based on commercial reagents, and it's difficult to have an idea of what is good or not. So we decided to have our own approach to store the sample, concentrate, prepare. First, we test storage of the sample. We storage with filtration, without filtration, we did test several systems, and we do a quantification every week for 12 weeks. And what we see is that what is important is to have a storage at -20. So we decided to keep it at -80 because I have the place in my freezer. And it was a good idea because I must use 20. After several months, there is a reduction in the RNA. So if you want to do this kind of study, it's better to keep the sample at -80. But for a short time, it's not a problem. After that, we test different concentration. So we did in the literature, there was ultrafiltration with centricon, precipitation with polyethylene glycol, ultracentrifuge, and we combine all this method. And at the end, I do that quickly, but the best thing was to do low-speed centrifugation, filtration successive, and after ultracentrifugation with a centricon with that. The problem is it's very expensive. I think it's 30 or 40 euro each system like that. So it was expensive, but it was the best system, and we did that. It was a first. We published that recently to propose this protocol, and we compared that with other laboratories who had other protocol, and it was the best for the moment. After we do the same thing for the sequencing, so it is technical, so I will not about this, but I will go directly to the results. Excuse me. It was a different. Tu m'as mélangé des trucs, mais c'est pas grave. Je crois. Enfin, c'est pas grave. Ou c'est moi qui les ai mélangés. Okay. So in this work, there was something curious. Because the firefighters survey after the different districts in the city. So they surveyed different districts, and this was something curious. There was a district in the B7. So B7, it's here, and the B7 had not the same epidemiology than the other of Marseille. At this period, we were on the variant. It was mostly UK variant. And UK variant, you see, all the people were supposed to have all, this variant. But in this area, people had something that should be this. But this bug was not circulating at this period. So we found that very, very curious. So we did genome sequencing, and by doing genome sequencing, okay, you see that in the general network of Marseille, people indeed had this variant. It was the alpha variant or UK. So it was corresponding to what we found by the PCR. But when we did the sequence on the B7, we find that there was another variant, and it was this one. So it was completely coming from nowhere. We had no idea why we have in this district this curious epidemiology. So it would have been nice to search for it, but it's difficult because you need to have the people in the atom and to learn how they live, what is their religion, if they go to abroad. So it's too complicated. But what we see, by the genome sequencing in a district, it was possible to deduce that the people were not infected by the same variant. And there is a team in Nice. They did exactly the same thing, and they test different. Or in Nice, it's different. So in Nice, all the sewage are separated in districts like this, and they come all, and you have East, West Nice. And what they see in Nice, in example, you have a variant here, this one, Avenset. It appeared very early in January, and it was not present in other place in Nice. And after that, you had this variant in blue. This was UK variant, who appeared very early here. It appeared, it appeared 1 month before the two. You see, it was not present in January, and here it presents in January, and it is unique where it presents in January, and after it becomes the dominant variant. So it's possible only on the sewage to see a different epidemiology according to the district. We tested also aircraft. So we did that also with the firefighters that are to the airport of Marignan. And during the period of Christmas, they took sample from the 2 airplanes coming from Addis Ababa, Ethiopia. After I have not good knowledge of what was Addis Ababa. In fact, it is a platform, and the people in the place. At the beginning, I imagined that people were coming from Ethiopia, but no, they don't come from Ethiopia. They come from Comoro, in fact, and they stop at Addis Ababa, and after they transfer at Addis Ababa, and they come to Marseille. So in 2 aircraft, they take the sewage, 2 sewage samples, and they test for 1 flight. They did antigenic test to the people that were in the airplane. So we did the same procedure, and on that we see that we had the same result in the two samples. In fact, we see that we have this BA1 and BA1.1. In fact, is Omicron variant. So it is the first introduction of Omicron variant in our city. There is no Omicron variant. There was very few. It was around 20% because it arrived early in Paris. So in Paris, it's France, of course. But in Marseille, it arrived later, and it was the first introduction of the Omicron variant. And worse. And what we see for 1 flight, they test 12 passengers, and among 12 passengers with antigenic test, 11 had a positive PCR. I don't know if you remember at this period, to take the airplane, you need to have a test and you need to have a sanitary pass. So it was incredible. So when I see this result, I found that very, very strange. So we try to understand why it's possible to people coming from Ethiopia. And I discussed with the firefighters, and they said, no, it's not Ethiopia, they come from Comoro. Oh, Comoro. So I have a student from Comoro. I have a PhD student from Comoro and a secretary from Comoro. I say, oh, what happens in Comoro? They say to me, you don't know, it's possible to buy it. You have not to do the test, you can buy the test. So I understand the reason. Nearly all the flight was positive to Omicron. So it's curious way to imagine that you can stop the viruses at the border. The viruses, it's easy for them to come in the country, and mostly in the country where you have a lot of flight, of airplane, of train, and a mix of population. So after that, with our colleagues, we now monitor the viruses for other viruses, not SARS-CoV-2, but look only RSV and influenza A and B. And this is very interesting. Here you have the sewage of Marseille, and here you have the case tested in our laboratory. And you see here, you have the peak, and you have the peak. Here, the peak of patients is here. You take flu, you have a peak here, and here you have a peak. After here you have a peak of flu, here you have the peak of patient. Here you have a peak of flu. This is flu A, flu B. Flu B, you have a peak of flu B. Here you have the peak of patients. So approximately you have 2 weeks between the peak in the sewage and the peak in the patient. But is it interesting? I don't think so. What is interesting, what would be interesting, and it would be very difficult, is to 2 weeks before to predict that when will start the big epidemic. This is very important because especially for RSV, you know RSV is a disease for the small children, and they have this kind of epidemic. You need to open beds in the hospital. So it would be very important to predict 2 weeks ago, 2 weeks before the start of the epidemic, to say, okay, the epidemic is starting now, so you need to prepare, you need to open beds to receive all these children. And now each year we begin, excuse me, we begin to open bed at this period. It's too late. So we need to have a survey in the sewage to be sure that it will be coming. The problem is, it is the intensity, you know, yeah, it's low, up, it's increased. And that I don't know how to manage that. So it will be probably more complex than expected. So the conclusion of the part 2, so the sewage sample, it's very interesting to monitor the virus circulation. So it's possible to use that also for gastroenteritis. It's very easy, even it's logical. It's possible to do that for viruses that are excreted in urine. So it would be very good for arboviruses, you know, an example, dengue or Zika, chikungunya. We have a problem in south of France now. We have the mosquito Aedes albopicus that is transmitting these viruses. And we have people coming with the airplane, and they go in their family, or they go to back home, and they can be the mosquito can be infected, and we can have secondary case in local case in France. And this happened, but it's not very common. But we could imagine to test the sewage in the airplane, the seawater of the airplane, to say, okay, there are people in this plane that are infected with the virus. Of course, there is no big quarantine, but it's possible to say the people, you should be tested. All the passengers, you should be tested. Maybe you are infected with the dengue, chikungunya, or Zika. The sewage monitoring is independent of case testing of the severity, and so it would be very interesting to health authority to monitor even the politics they have, you know, the policy, the health policy. You understand? It is impossible to have a health policy when you say that the France is a unique place. No, France is different. You see, the north of the France is different from Bretagne, it's different from Aquitaine. So it would be interesting to monitor the epidemic on the sewage instead of doing this from Paris and only on the number of cases. It can be used to monitor the presence of variants of genotypes. And now we think that it could be interesting to target area with high risk of transmission, or the high risk of transmission. We know that for the viruses it is school or nursing home. You know, if you test the sewage water of a nursing home, you can detect very early the beginning of an epidemic and, okay, protect everybody. It is possible to anticipate epidemic peaks, and for the airport, it would be very interesting to follow the circulation of the viruses. So it will be my last slide, and there was this proposal it was Lancel Global Health, and I think they have a good idea. They propose, in fact, to have a survey based on the airplane and in the airport to test all the viruses and to see the circulation of all the viruses. It's a very nice article if you want to have an interesting lecture this evening. So I will acknowledge all the people who did this work, especially my old friend Philippe Colson, who is an expert in the genome sequencing of viruses. He knows all the variants. I can't do that. He knows all the variants by their little name, B1, P.1.5. He knows everything. The people of the firefighters, the biosafety level 3, Nathalie, the student and technician, Priscilla, who did the genome sequencing, my assistant and my PhD who did the sequence analysis, and the guy who did the electronic microscopy, and all the team of the biosafety level 3 laboratory of the institute. Thank you.